Hello, friends. So I'll be talking on this the topic Aspergillus in India, burden in India. Just a brief overview on the Aspergillosis and the way we diagnose, with a little bit of emphasis on Galactomannan, because this was a question in one of the exams that asked about Galactomannan and beta glucan uh, as a diagnostic tools in fungal infections. So when we talk about any fungal infections, we need to have an overview of the classification. So this I had covered in the previous talk as well. So just to refresh our memory, when you talk about fungi, broadly divided into yeast and molds, and the common infection that we see in ICU is always with yeast, and the commonest yeast is the Candida albicans. 80% of our infections will be due to yeast. The other yeast is Cryptococcus. And the molds, Aspergillus comes under the category of molds, and the molds constitute around 20% of the infections. And we did talk about auris being problematic now, in addition to albicans, and the outbreak in Candida auris is something that is becoming more commoner now. So when we talk about molds, broadly classified into septate hyphae and aseptate. So in aseptate, you have zygomycetes and mucormycosis. In septate, it's again classified into dematiaceous and hyaline molds. And your aspergillus comes under hyaline molds. Aspergillus and fusarium and dimorphic, it is histoplasma. And there's another new one called emergomyces. So this is an overview just to refresh our memories as to how we classify fungal infections, and useful for all trainees to remember that Aspergillus comes under hyaline molds in septate hyphae, and it constitutes around. And in molds, the commonest infection we see in ICU is Aspergillus, followed by mucormycosis, fusarium, and so on and so forth. So again, to refresh, what are the risk factors for mold infections? We know the risk factors for Candida. So the risk factors for mold infections will be predominantly your hematological malignancies, solid organ transplants, or solid organ malignancies on chemotherapy, where they have neutropenia. For if someone having neutropenia for more than 10 days, defined as having neutrophils less than 500, or anyone who is on AML remission following induction therapy, or someone who is undergoing stem cell transplant, allogenic. And mold infections are more common in allogenic hematopoietic stem cell transplant as opposed to autologous stem cell transplants. And HIV patients, although the burden is coming down with good heart ART therapy, so HIV or AIDS, they are also at a high risk of developing mold infection. And anyone with a end stage organ dysfunction like liver disease, DKA, are vulnerable for mucormycosis. We all know that. And someone with end stage lung disease is a definitive risk factor for mold, and more so your aspergillus. It is found to occur in anyone with a compromised lung function like COPD. And what is learning for all our ICU trainees is ARDS patients also are at a risk of developing aspergillus. And I'll show you some studies where uh, aspergillus is found in significant percentage of patients in autopsy in ARDS patients. And someone who have diseased lungs like cystic fibrosis or pulmonary fibrosis are also at a risk of aspergillus. And someone with granulomatous diseases like tuberculosis and sarcoidosis, they are at a higher risk of developing aspergillus in the lungs, especially the cavitatory form of aspergillus is more common in someone whose lung is already affected with tuberculosis or sarcoidosis and so on and so forth. Aspergillus tends to occur. I'll show you some data. And solid organ transplant are at a risk for mold infections, graft versus host disease. And this is another important aspect. Someone who's on a long-term steroids. When we say long-term, who is on steroids for more than 3 weeks at a dose of 0.3 milligrams per kg. For 60 kgs, it comes to around 18 milligrams of steroids. If they're on that dose for more than 3 weeks, they are at a risk of developing mold infections. Or someone who is on some immunosuppressive drugs with T cell suppression for about 3 months. So 3 months to 3 weeks, if 3 weeks, more than 3 weeks, or they are on steroids, they become a risk. Or someone who is on some sort of an immunosuppressant for T cell to reduce the T cell function for 3 months, they are at a risk for mold infection. So just a pictorial representation of the typical risk factors. For aspergillus, one needs to bear in mind any condition that has affected the lungs or that has weakened the host defenses within the lungs, like COPD, fibrosis, granulomatous disease, tuberculosis, ARDS. So these are all the risk factors. So any individual where the lung is affected, they become a risk factor for aspergillosis. So when we talk about aspergillosis epidemiology, there are different species of aspergillus. So aspergillus fumigatus is what we tend to articulate more often. So there was one study done in US where they have looked at 218 infections of aspergillus in 24 transplant centers. They found fumigatus is the more common. So aspergillus fumigatus constitutes 67% of aspergillus infections, followed by flavus. Flavus occurs in 13%, followed by niger, Aspergillus niger, which occurs in 9%, and Aspergillus teres happens in 7%. So this is the sort of a breakup of the species of Aspergillus. So fumigatus is more common, followed by flavus. So when we talk about Aspergillus infection in a human, I'm sure many of you would have heard different terminologies. There are four different types of or distinct types of infections that happen. The ones we tend to see in IC is invasive aspergillosis. That is the commoner one. Then there is chronic or cavitatory pulmonary aspergillosis. So this is typically seen in patients with tuberculosis where there is already a cavity that is formed, or sarcoidosis, or any lung destructive lung lesion. So cavitatory pulmonary aspergillosis tends to happen. Then this is something you must have heard, which happens typically in asthma, allergic bronchopulmonary aspergillosis. So this typically happens in COPD and asthma patients who are using steroids, so on and so forth, ABPA. So there is a new terminology that has come, which is called SAFS, which is called as severe asthma with fungal sensitization, SAFS. So this is a new one that has been added up. So when we talk about aspergillosis, the spectrum of the disease comes into four components: invasive aspergillosis, cavitatory, allergic bronchopulmonary, and severe asthma with fungal sensitization. So we looked into some of the data in India. What is the occurrence? So this is Indian data, acute myeloid leukemia annual incidence. This is as per 2016, around 2 lakhs to 25,224 leukemias. So where they looked at invasive aspergillosis occurred in 13%. This is our Indian data. And in cancer, so in lung cancer, 2% of the patients had aspergillosis. Stem cell transplant, 10% of them had invasive aspergillosis. When you look at solid organ transplant, especially patients with lung transplant, the risk of aspergillosis was found to be high. 20% of them can have invasive aspergillosis, followed by heart transplant 6%, liver transplant 4%, and kidney transplant 2%. So understanding that these transplant patients will be on sort of immunosuppressive drugs. So one take-home message in back of our mind is if any of the lung transplant centers, they tend to have more aspergillus as a problem. So the intuitive thought in everyone's mind is anywhere the lung is involved, aspergillosis as a mold infections tend to occur more commonly as opposed to other mold infections. So that is something we need to keep in mind. So lung infiltrates, and in a patient who are at the risk of developing mold infection, aspergillosis should come in top of your mind. And AIDS patient, around 4% of them had aspergillosis. So this is something which is again Indian data, which is good to see. As I said, all these are 2016 data. COPD, the burden in India was around 58 million in 2016, and the aspergillosis occurred in 1.3 to 3.9% of these COPD patients tend to have some form of aspergillosis, mainly allergic bronchopulmonary aspergillosis. In asthma, the burden of asthma patients in India was 40 million. Of that, 5% of them had aspergillosis. And severe asthma, especially in patients with severe asthma, 10% of them tend to have aspergillosis. So this is something, these are the Indian statistics. So aspergillosis is there in all this sort of a spectrum of patients, and that needs to be kept in mind. And in patients with severe asthma with fungal sensitization happened in 33%. So this is the Indian data on aspergillosis. And what about patients with HIV? So HIV, the cavitatory pulmonary aspergillosis along with TB happened in 7%, plus or minus TB happened in 10% of the patients. In non-HIV, it was much less, 3%, and it was 19% where there was cavitatory pulmonary aspergillosis. So So cavitatory pulmonary aspergillosis, especially when there is cavity. So any patients with cavity, 22% of the patients with cavity. So aspergillosis occurred in within 2 to 5 years in someone who's had cavity, 6.5% of the patients. And the end of TB treatment, around 10% had aspergillosis. So which means to say any structural sort of a destruction or structural abnormality in the lungs that becomes a risk factor, and more so when it is with a concomitant presence of tuberculosis, the risk is more. At the end of TB treatment, the risk of aspergillosis was 10%. So, and what about the mortality in cavitatory pulmonary aspergillosis? The mortality was 20% at the end of first year and 7.5% as the annual mortality risk with cavitatory pulmonary aspergillosis. So, which means aspergillus is very much present and more so in India where TB burden is there. If someone has a cavity, one should bear in mind aspergillus can somewhere affect in the range of 2 to 5 years, and 6.5% of these patients with cavity can get affected with aspergillus is something that one needs to keep in mind. So now we'll slowly move to the diagnosis. So diagnosis, CT scan is the main diagnostic modality with regards to imaging, especially when lungs are affected. So the typical feature I'm sure most of listeners would have heard is the halo sign. And this is the crescent sign. This is the air cavity within the halo. This is post-treatment of aspergillosis. You will see the more confluence of the opacities that are present with the crescent that is present. So this is the halo sign and this is the crescent sign that is present during the recovery phase of aspergillosis. So these are the uh, typical hallmark features in the lung. In addition to this, aspergillus can present with diffuse infiltrates, can present with consolidation, can present with nodules, and can present with cavity. So these are all the different sort of a clinical spectrum. And clinical presentations will be typically with cough, shortness of breath, wheeze, and they can have chest pain and hemoptysis. So these are some of the clinical features. But diagnosis is mainly putting the identifying the patient who are at a risk of developing aspergillosis with typical symptomology and X-ray infiltrate. And obviously, we need to do certain tests like galactomannan. So the main purpose of doing this video is to just elucidate a bit of thoughts on galactomannan. So galactomannan is the test is a good screening tool for recognizing or identifying patients with aspergillus. So galactomannan is a polysaccharide which is present in the cell wall and cell membrane of the aspergillus. So uh, the tests that have evolved is to identify this component, this polysaccharide component, galactomannan, which is present within the cell wall and cell membrane of aspergillus. So, so the test that has been widely adopted to test for galactomannan is double sandwich enzyme immunoassay, and it is done by Sanofi. It is called Platelia. So the way it is done is the monoclonal antibody EBA2 is used to recognize galactose furanose side chain. So that is the component that it tends to binds to and recognizes galactofuranose side chain in both serum and bronchoalveolar lavage fluid. So anywhere the fungus is present, so this galactomannan, which is a polysaccharide, is identified by this enzyme-linked immunoassay, which is Platelia. So the measure of galactomannan test is optical density index. So which is the optical density readout of the patient. It is a relation of optical density readout of the patient compared to the mean optical density, which is twice the threshold. So it is the proportion, it is the ratio of optical density readout that happens for the patient in comparison with the reference value, which is twice the threshold. More than or equal to zero point 0.5 is considered positive for galactomannan. 1 to 1.5 is lower false positive. It means it gives lower sensitivity and higher specificity. So FDA recommends more than zero point 0.5 result of galactomannan in serum and BAL as positive. For BAL, higher levels of galactomannan can be considered as positive, like more than or equal to 1 is considered positive for BAL. But for serum, more than zero point 0.5 is considered as positive for galactomannan. So for all the trainees, the way it is, so galactomannan is simply a polysaccharide present in the cell wall and cell membrane, and monoclonal antibodies are used to recognize this galactomannan furanose side chain, which is present wherever the fungus is present, and optical density index is the measure, which is a ratio of optical density readout of the patient compared with the reference threshold. So that's all we need to know. And there are studies done to see how good is galactomannan test as a tool for diagnosis of aspergillus. So this is the biggest study, which was a meta-analysis of 50 studies looking at 5,660 immunocompromised patients. They looked at optical density index of more than 5 for galactomannan. Sensitivity was 82%. As you see, it was very significant, and specificity was 81%. Positive predictive value of this test was less than 50%, and negative predictive value was more than 90%, which means if this test is negative in a patient who is at a risk of developing mold infections with the lung infiltrate, if this test is negative, you can conclusively rule out the aspergillus. But if this test is positive, then you may have to do further tests to establish the diagnosis and treat as aspergillosis. That's what it means. Because sensitivity is good and specificity also is reasonable. And as you see, confidence intervals are significant, which means it has a good sensitivity and good specificity. And the utility is for high risk patients, which means the clinician must have exercised his clinical acumen in doing this test only for a high risk patient, not for every patient, and in patients with hematological malignancies or solid organ tumors who are on immunosuppression. So there the yield is better, and the positivity and the yield of this to recognize is high in patients where the suspicion is more and the prevalence of aspergillus is more. It has a better predictive performance. So this test, one has to exercise good clinical acumen in trying to use this test where the suspicion is high. So suspicion is where the patient has all the risk factors with a lung infiltrate. So those are the patients where you do this galactomannan test. But there are certain caveats for galactomannan. Sensitivity of this galactomannan test comes down when someone is already on antifungal treatment, and false positives can happen. This is a problem in ICU. False positive can happen in someone who is on IV antibiotics like piperacillin, tazobactam, or amoxicillin. Most of our ICU patients would be exposed to these antibiotics, so that's where it can cause a bit of a problem. Someone who has graft versus host disease or gut mucositis, or who has received IV immunoglobulins, that can be false positive. And after galactomannan test is come positive, weekly testing has to be done every twice a week to see the whether it's becoming negative, to confirm that the treatment is working. So the FDA recommends either doing serum ban, serum galactomannan, or bronchoalveolar lavage fluid, or even if you have suspecting aspergillus in the pleural space, pleural fluid also. So which means any fungal elements present in anywhere, you can do the galactomannan test. So even CSF can be done if you are suspecting aspergillus in the brain. So this is something about galactomannan. It's a simple test. So if this is asked, so all the trainees can keep in mind it's just a polysaccharide present in the fungal cell wall, which is done by using enzyme linked assay, which is a polyclonal based antibody based enzyme, polyclonal based assessment of this galactomannan. So I'll just end this with a treatment of invasive aspergillosis. So when you look at the guidelines for aspergillosis, when you look at IDSA guidelines or European Society of Clinical Microbiology and Infectious Disease Assessment, or ECL, which is European Society for Leukemia. So the recommendations is voriconazole or isavuconazole. IDSA gives more weightage to the voriconazole as a drug of choice for aspergillosis. So for critically ill patients, the IV formulation of voriconazole, the dose is 6 milligrams per kg twice a day for 2 doses, followed by 4 mg per kg. If it, and then to be de-escalated to oral, which is 200 mg twice a day for many weeks. So that is the recommended sort of a drug. And as I said, IDSA gives more weightage for the voriconazole as a drug of choice. So now the question is, there is azole resistant aspergillus also, which is evolving, which is reported from these Dutch studies. So if there is resistance, then liposomal amphotericin B becomes the second alternative. So there are certain studies which has looked at combination. So this was an Italian sort of a study, which is a CFEM study, mycosis, where they have looked at usage of combination in azole resistant aspergillosis. So here they used combination like caspofungin with oriconazole in 42%, caspofungin with liposomal amphotericin with 24%, and liposomal amphotericin with voriconazole, and they found no difference in any of the combination. So this combination to be obviously reserved, and the response rate with the combination was 73%, mortality was 17, which means this combination is reserved only where the azole resistance is there for aspergillus. Otherwise, the drug of choice remains voriconazole or isovoconazole. Voriconazole is the first choice, and the dosage, as I mentioned, is 200 mg twice a day for a long period of time. So that's about the overview of aspergillus, friends. So the key elements for us to ponder on is the role of galactomannan. So if you have a patient who is immunocompromised and who a clinician believes is at a risk for mold infections with a lung infiltrate, then the suspicion of aspergillus has to be kept in mind. And the diagnostic approach is to do a CT to look at any lung involvement, followed by galactomannan, which is a polyclonal antibody, monoclonal antibody based assessment of galactomannan, which is a polysaccharide present in the cell wall and cell membrane of the fungal elements. So this was one of the publication we made about in COVID, which is called Kappa. So COVID associated pulmonary aspergillosis and pneumothorax, where we did do galactomannan and pick up this infection and proved it in histopathology as well. So thank you one and all. So request all our esteemed listeners to submit their valuable work to our Journal of Acute Care, which comes out every 3 months. So already 5 issues are out. So request you all to present your research work. You can visit my website www.drpradeeprangappa.com to rehead to this lecture. So thank you one and all.